Good evening, everyone. We're going to get started. Thank you for attending ACAM's eMedTalk with Dr. Ahvie Herskowitz, President of ACAM. We are talking about COVID-19 tonight and updates pertaining to it. Please submit your questions using the chat box over on the right. Questions will be addressed at the end. Then we have a couple items, upcoming events for ACAM. Briefly mention these. So we have a chelation program that's going to be virtual March 27th. Then our April webinar will be on nutrition and DNA. And then we are also promoting a mold toxicity workshop from one of our speakers at the virtual meeting, Dr. Neil Nathan. And we'll send out more information about that in the email as well with the recording. We want to introduce our speaker tonight, Dr. Ahvie Herskowitz. Dr. Herskowitz is the president of ACAM, an international leader and educator in the field of personalized precision and integrative medicine. Dr. Herskowitz's extensive training includes a medical degree from the Albert Einstein College of Medicine, then residencies in anatomic pathology and internal medicine, and then a fellowship training in cardiology at the Johns Hopkins Medical Center. In 2010, he formed Anatera Medicine, based in San Francisco, California, to provide a world-class integrative medicine facility. He is the founder of the San Francisco Stem Cell Center, and he has over 4 decades of experience in medicine, cardiology, immunology, regenerative medicine, and pathology. And he is our senior academic anti-aging doctor in the U.S. I'll give it over to you.
Thank you, Katie. So let's get started, everyone. We have a lot of information to review. The last time we did this was around 7 weeks or so ago, almost 2 months ago, and a lot has happened, as you well know. Let's just start, and I hope that we'll have plenty of time at the end for questions. As an update, we now have 1 in every 12 persons in the U.S. is tested positive with the PCR test that I'll talk about a little bit later. That's a positivity rate of 8.4%. And we've done many tests, over 300 million tests. And basically, we've had an explosion of deaths in the last 2 months, now 475,000 deaths, or roughly 1 in every 700 persons in the United States. The fatality rate is here, and the number of hospitalizations currently is not close to its peak, but it's roughly at 2/3 the peak hospitalization rate in the past. And this is just the current data as of a few days ago. Now, I wanted to focus on patterns, and I think it's instructive to not just look at the US, but look internationally and try to understand certain things that have been happening over the last, pretty much since Thanksgiving and Christmas, and then into New Year's. When you look at this particular slide, it talks about new confirmed cases, and I don't think much about these types of charts that deal with cases because it's a function of how many tests you're running. It's really the positivity rate that one has to look at, and in this database, there is no positivity rate data. So when you look at the blue, which is the United States, we have a hump after Christmas and then a hump after New Year, but in a different pattern in the United Kingdom. But of course, they're both rising and then eventually falling about a week after New Year's. And this will become more evident why it's important in a minute. When you look at this chart, which is deaths, these are average deaths normalized by population, because of course the US is around 6 times higher population than the United Kingdom. But this is normalized, so you see this enormous peak at roughly double the rate in the US. So at this rate, this would be unsustainable for a developed industrialized country. But it starts rising in the UK after New Year's, and whereas we start rising after Thanksgiving and continue, but then we're flat. And so this is why there's concern that the UK variant is producing this rise. But after the first of the month, there's been a dramatic fall in the UK cases of death. So this trend will hopefully soon continue downward and then reflect our level. But we have not seen any change in the level of deaths in the US roughly for the last month. When you look at and you add other countries in Europe, and I could have made this dizzyingly busy, but just choosing two of them that we know about from a long time ago, we know that in the left side of the graph that all the countries in Europe had more deaths than the United States by a factor of 2 or 3. But now the US is smack in the center between the UK and France and Italy. The same could be held true for Sweden and Germany. Germany is even lower. But the different trends have different patterns. And you notice that Italy had a bump way before Thanksgiving and then has come down since then. So patterning is very difficult to understand other than within a single region. So when you look at who is dying, and again, this has been really stable over the last year for that matter, for the 10 months that we've had data on, and roughly 81.2% are greater than 65 years of age. And then when you combine that with the 55-year-olds or higher, you get 93% of the population that has the most severe form that leads to death. So if we can, overall, in a public health perspective, if we vaccinate this group above age 55, and certainly first do the 65 and older group, and particularly those with pre-existing conditions, we'll be able to make a dramatic change in this pattern. Because right now, we'll see later that if we continue this particular rate of death over and above what we anticipate, some data suggests that we will end up to have 800,000 additional deaths at this current level. But that data I'll review in a minute. So who gets this? I mean, this is back from July. If you notice the red circle on the title, this is 6 months ago. And we knew that when you had hypertension, obesity, metabolic disease, I think that really meant diabetes and cardiovascular disease, we captured the bulk of the cases. And if you remember from other lectures, this is the 7th one in the series, you'll remember that I said that the average patient who ultimately died had roughly 3 of these conditions on average, and only a small portion of 1 in 16 people that passed away had none of these conditions. So it was really a small number that didn't have any of these. But then hypertension, obesity, metabolic disease, and cardiovascular disease, I'll get to that in a minute, but really the asthma and the chronic lung disease was lower than we thought it would be. And immune suppression was lower than we thought it would be. And then all the way on the bottom, you'll notice this really tiny proportion of patients with autoimmune disease. And since we're all concerned with post-viral, post-COVID autoimmune conditions, as I'll describe in a few minutes, this number is remarkably low. So autoimmune patients seem to be not at greater risk. But now it takes 6 months later and you go to the same site, the same CDC site, and you look for it saying, listen, I wonder whether this pattern is the same, and you get a different table. The table doesn't even include heart disease. It includes a much smaller proportion of hypertension, a much larger proportion of patients with pneumonia for that matter, and then smaller proportions of diabetes and so on. So I don't really know what to make of this. Perhaps this is a function of the data stream stopping 6 or so months ago directly to the CDC, but it's hard to understand. But from the prior slide, we understood that inflammation was the primary driver of serious COVID adverse events, and this data somewhat supports it, but is inconsistent. And then you ask, well, what's the total number of deaths above average? And this is very, very controversial. There are a lot of data I get from all different sources every day that suggest that we have no excess deaths in the developed world. And this data, I'll explain why that's so confusing. Well, if you look at the top bar, you have a small number of people with respiratory disease. This is inconsistent with the prior slide. This is also CDC's data. And then roughly 63,000 plus 43, roughly about 100,000 extra deaths between Alzheimer's and circulatory disease. And then another 16 or so percent, another 16,000. But this all adds up to a number, and it's roughly about 120,000 excess deaths, which is a lot, but much less than would be advertised. But then you look at the other CDC websites, they talk about the same thing. And you notice on the left side, it says January 2018 with a small number of extra stars here. And that came from the bad influenza season of roughly 50 to 70,000 extra deaths in 2017, 2018. And then we're flat. And then you go over to the right, and we start in March, April of 2020 with the classical 3 humps that we've had in the United States. And when you add these up, you end up with around 200,000 extra deaths. And that's a lot more than the prior slide, but that's it. And then you go to a third database. I don't know who runs the ourworldindata.org, but when you notice the same 3 humps, this is comparing extra deaths in 2020 versus the average of 5 years prior. You notice that when you add them all up week by week, that you end up with 395,000 extra deaths in 2020 in the United States. And there are databases that show similar findings in the UK, Germany, Spain, and France, and Italy. But how you get these data is unclear. But death should be very easy to measure, frankly, unfortunately, but frankly. But you get different numbers. And I think that it's likely, overwhelmingly likely, that we do have extra deaths in the developed world, but we really don't know how many. Well, where do patients die? I think this is interesting for just a few brief reasons. We see that 2/3 of all the people die in the inpatient healthcare setting, and that's not surprising. And then about 1 in 5 people pass away in the nursing home or long-term facility. But this is a little confusing because the information across the United States suggests that 40% of all the deaths, so half the deaths are in the nursing home, half those poor patients die in the nursing home, and half of them die in inpatient facilities. And then only 6% of folks in the United States, this is early on, more likely than not in the early epidemic, die at home. But this is a major problem in the developing world, and you'll see what I mean in a few minutes, where we have information from one of the countries in South Africa in particular. So we know that there's 1.5 times the rate of patients of color that are dying. I showed this many times over the last 6 months, and now this has been tracking very, very clearly. But when you look at the most recent CDC data, again, there are twice as many patients who are Caucasian white in the United States as are Hispanic and non-Hispanic Black. So roughly this is equivalent, 30%, 60%. But you'll notice that the Hispanic population used to be closer to 9% and now is double. So over the last 6 months, the Hispanic population has taken a particularly difficult route with COVID that is still yet to be studied further. And you say, well, we all have heard the story about Sweden, and Sweden did not lock down versus the other Scandinavian countries and the other countries in Europe. And when you look to the left side, back in April, they took a hit. When you look at the graph closely, I hope you can see it's roughly at 1 per 100,000 people on average daily deaths. So, and then they are flat. And then we said, well, in the middle group over the summertime, we said, oh, this shows really evidence that you don't need to lock down, and that really supported that. But all the different Scandinavian countries that did lock down also had similar patterns of flattening. And now you can see that there may be a reason to suggest that Sweden is paying a certain price for that freedom, although Denmark is also, but these other countries, Norway and Finland, are not. So Sweden, all these countries are quite small, but they have large cities in them, each of them, particularly Stockholm and Sweden. There are very difficult lessons to be learned here. I think one thing that I take from this is that right now Sweden is lower than the United States in terms of overall death rates. And one thing that I can say that is clearly different is that the school population has always been intact in Sweden, whereas we have largely left the kids out of school. But it is difficult to come up with clear patterns with this particular virus. So then you go to South America. There was always a story early on, some of you may have heard, that Uruguay was the poster child for effectiveness for virus prevention and as a society, and they were remarkably different than Brazil, which is a much larger country, of course. And now, after Thanksgiving and Christmas, they've been rising, but not to the level of Brazil. The trouble with data from India, Brazil, South Africa, and perhaps other countries that I don't follow closely is that I don't have a great deal of confidence that the numbers are accurate, because they're not counting patients that die at home. So then you say, well, we know about the South African variant that has been around since the time that the pattern was flat, about minus 70 days, and then their death rate started to rise dramatically. And it looks like, well, why is this considered to be a big problem? Because it peaked and then it's come down. And there's basically has been no large vaccination program in South Africa. In fact, they're still debating which vaccine to use. So what's the problem here? It seems to be that maybe the variant is not that bad. But then you look at this next slide here, and then you say that the death rate attributed to COVID-19 is much higher than is anticipated, because they're now in this particular diagram that was produced, in fact, by The Economist, which is now perhaps more accurate than the WHO. It's not clear, but there's a lot more patients that are anticipated in South Africa to have passed away with COVID or from COVID. No one knows, but they're dying at home. So the South African variant still remains a high level of concern for me as a tracker of this. And at this time, we have no reason to believe that South Africa is under control. But then one of the mega trends that has been completely stable over the last year is the remarkable difference between Asia and the United States. So I just used two examples here, Japan and Korea. And we're talking about a 30 to 50 times greater death rates in these two different disparate regions where you can trust the information. Now, that's why we chose these two countries. But this needs to be tackled and studied in a much more systematic way. It's not obviously just genetics, because Japanese and Korean Americans are tracking the white population and the other Asian populations, and they have higher incidences, but it's not just genetic protection. So let's get over to the vaccines now, because this is on everyone's mind. We know we have the two RNA vaccines available in the United States, and now the Johnson & Johnson with an older technology that's upgraded, but an older adenovirus technology has now been subject to approval, perhaps as early as late month, and then the Novavax and then the AstraZeneca that's been approved in Europe. Despite a very sketchy program that we have, very, very, very sketchy state by state, county by county, city by city for vaccinations, we're roughly at the 60 million rate as of 3 days ago. We've administered 42 million doses, of which around 25% of the patients have already gotten 2 doses, roughly 10 million, and then the remainder have received 1 dose, and this is going to rise every day. But if you look at the number of doses that have been delivered as 60 million, in a few slides, I'll explain that we can well have covered the entire highest risk population of over 65 with that type of number. As the numbers grow, we will be able to bring down, more likely than not, be able to bring down the death rates dramatically, as I'll show has already been shown. So this is not going to be a virology lecture. The coronavirus, everyone knows, has the spike proteins that interact with the ACE2 receptor and so on and cause the pro-inflammatory state. So we have to buffer them. So these RNA vaccines are put into a new formulation, which is lipid nanoparticles, so that they can enter the cell. These are tiny particles, and they can enter our nucleus and so on. So we're just trying to go through this rapidly. And ultimately, the only thing I want you to know about this slide is that as it enters, it ultimately has to interact with our DNA and then produce a spike protein that gets transposed into the surface. And once it's on the surface, B cells can be attracted. They can call T cells. helper T cells and ultimately cytotoxic T cells as well. And this is sort of Immunology 101. And ultimately, these antibodies will bind, and these antigen-presenting cells will produce a whole slew of T cells. Ultimately, they'll be called memory T cells, and that will provide us with long-term protection. That in other viruses would provide lifelong protection. There's a controversy as to how long the protection will last, but if you read any article that talks about neutralizing antibodies, understand that the bulk of the long-term protection is not created by antibodies, it's created by T cells. What do we know about these vaccines? So we have the two data sets, and you'll see that they're quite different. The Moderna data set is presented in two age groups, the 18 to 64 and the greater than 65. And without going to large tables, I wanted to just summarize a few points. Firstly, the adverse events in this case include what I call only grade 3 adverse events. They're not the most severe, grade 4, and then the serious adverse events that require hospitalizations, which are not found in the clinical trial. So grade 3 or higher, headache, myalgia, fatigue, arthralgias, that's what is primarily seen. They also have, the most common side effect is pain at the injection site. But basically, 1 in 6 persons in this age group, in the 18 to 64 age group, have adverse events of this particular moderate type, whereas the older age groups are less. And this is to be anticipated because the vaccines were produced to have an effect in the older population, and we'll have to deal with the relative immune suppression of the older population. And so the younger population will respond to the antigens more robustly. So that's the Moderna data for these types of usual adverse events. And you'll notice the data looks different for Pfizer. They cannot be easily compared. This is less than 55 versus greater than 55. But you look at the numbers and fatigue. This is moderate fatigue after the second dose. I have to say, I forgot to mention in the Moderna as well as the Pfizer that these are cumulative. These are for both doses, but roughly the second dose produces twice as many adverse events as the first dose. So you can anticipate that for yourselves and for your patients. So fatigue, severe is relatively low, but it's still 2.8%, but 10-fold greater for moderate and 25-fold greater for headache and so on. So these are extremely common. They do knock some people out for a day or two. The elderly patients in Norway that we all have heard that passed away after receiving vaccines may have passed away because they had these types of fevers and fatigue and so on. It may not have been related to the vaccine. We just don't know at this time. So then you say, well, what about anaphylaxis? Now we have enough cases now to understand the general numbers. And right now you could say that Pfizer has a higher risk of anaphylaxis than does Moderna. They're both relatively low. Again, this reports on the Norway situation with Pfizer. And again, if you're very old and infirmed or have end-stage disease of some kind, whether it be cancer or immunosuppression for other reasons, and you develop severe fatigue and severe diarrhea, you may end up to be hospitalized and pass away from that. So it's unclear. But right now, it's relatively low, but it's something to watch for. I'm not surprised by these numbers. What I am much more conscious about is the autoimmune states that larger numbers of people will experience. Some of them have experienced it acutely, but the larger number, much larger number, may be anticipated in the future. So we have the currently available Pfizer, Moderna. We know that they're new technology. We know there's a long list of concerns for long-term safety. We just don't have that information, and that's why we're all also excited to have other options like the J&J one that just filed for their application with FDA this week, and hopefully we'll get an answer by the end of the month. But these older technology vaccines are not going to be as effective as a whole as the RNA vaccines. They just show relatively lower efficacy rates, but not very low, because the RNA vaccines have shown extraordinarily high efficacy. I'm not saying I'm a proponent of them. I'm just saying the reality is they're exceptionally effective, but we have no idea what their long-term safety is, whereas these vaccines are going to be slightly less effective and in different populations with much better long-term safety results from other vaccines with like technology. I don't want to review this slide in detail. Suffice it to say that the title speaks for itself. It's an adenoviral vector. Means that it doesn't interact with our DNA and it cannot produce active infection. So when you look at the bottom lower part, it says these vaccines are very good at protecting against severe COVID-19 and death, just like the mRNA vaccines, but they're slightly less effective against mild disease. And they have more established technology, so that's why they'll be important, but they're also important for other reasons, other logistical reasons, because the RNA vaccines are very difficult logistically. So when you look at the J&J vaccine, it's complete 100% protection, I think, in the clinical trial, but we don't anticipate that in the real world, but against hospitalization and death, but a little bit less effective. And this has gotten a lot of play. The South Africa variant has gotten a lot of play with less effectiveness with the AstraZeneca and the Johnson & Johnson vaccine. But on the other hand, it is effective, and it is effective at mitigating hospitalization and death, but it only needs a single shot and refrigeration only. So the U.S. has purchased 100 million doses of this by June, and then I think 200 million doses by the end of the year. And it's similar with Novavax. The U.S., we've already purchased, assuming approval, sometime more likely than not later in April or so. And again, lower efficacy against South Africa, robust protection against this, but it simply doesn't yet mean that more people would end up dying with these variants if they got these vaccines. They may just get some mild to moderate illness. I don't want to get into the AstraZeneca vaccine that much. Suffice it to say that there's a typo in here. It says it's a single shot. It's not. It's a double shot. That got them into trouble, and I think will delay their approval in the United States substantially, because FDA doesn't like it when a pharma company says that a single shot did better than a double shot, and that's how they marketed it first, which was a mistake, I think, by AstraZeneca. So we have a lot of different choices, and the choices are going to explode. There are about 30 vaccines in development, and we're going to have a lot of different choices, a lot of different technologies. Right now, we only have the newest technology, which is highly effective, but we have a big question mark in terms of long-term safety. So you say, well, how many people do I need to really vaccinate to get this pandemic under serious control? And you look at the census, well, there's about 35 million people in the older age groups, and about 13% of the population. Well, if we then had 70 million doses to give 2 doses of either one of those 2 vaccines that we have currently available, we would cover them. And of course, the healthcare workers and all the frontline workers. So if we had roughly 100 million doses in the pipeline, then we'd be able to cover this group more likely than not. When we add the others, another 82 million, then we have a larger population that needs to. But the question is why are the public health experts talking about ultimately vaccinating 75 or 80% of the population, which ultimately means we'll be vaccinating the majority of people who have very low risks of symptomatic disease. So ultimately, if you get this group of everyone above 45 or everyone that's largely at risk, then you roughly need double these doses and so on. So we should be able to get to this area as a country by summertime. And then you have the confounding information that sometime in December, we first detected this UK variant, and this UK variant may be associated with the rise in deaths, particularly in southern UK, and London as the driver of that. But this has been present since October, and again in South Africa when it was flat, and then it rose again. So it's unclear what the associations are. There's a lot of information that seems to change weekly. In the UK in particular, it says 1 week it says it's not associated with more deaths, and then it says it changes its mind, and then it goes back and flips back and forth. And I don't find that very helpful either. So when you look at the timing, the UK variant is timed properly to explain these extra deaths. It has no impact on ours. The question is, why is the United States remained flat for the last 30 days, 30, 45 days? It's remained flat at this level that's at roughly 3,000 people a day. And when you add these other ones, I think we've all seen enough of these slides, frankly. So let's move on. So you say, well, what information can we have from another source? In this case, a small country with only a population of 9 million, I think, smaller than most of the states in the United States. But they did rapidly vaccinate a third of their population. And 6 weeks into the vaccine campaign, they had dramatic drops in all these categories here. And then when you look at the death chart, it shows as soon as the vaccination program began, they started seeing less deaths. In this case, if they have less death, they've had less hospitalizations, and all these numbers become clear. So if you can see, and I think the numbers suggest that they've already seen a 30% drop in deaths. So if you can see this number off to the right is 0.5. It's already significantly lower than the 0.7 that started with, and that's a 30% drop. And as it continues over the ensuing months, it will be one of the lowest death rates for a developed country in the world. So we expect that our death rate should come down. And if it doesn't, it would be unexplainable at this time. So I'm talking very rapidly because I want plenty of time for questions and answers. But this is, I think, a really important part of the perspective, and that is the long-term COVID-19 patients. Because my experience in the lab in academic medicine has been with post-viral autoimmune disease and how that's the basis for myocarditis and the molecular mechanisms involved. And this is one of the categories that is obvious now, that patients have these post-viral complications. And from my experience now, they're very, very ill. They're really broken. They're on the system level, system biologically, they're broken. They've had hyperinflammation for, however long they've been in the hospital. They barely survive. And they have all these things going on. And they have post-viral autoimmunity. Now, the one I want to talk about at some length is the brain and the heart. We know that patients who get hospitalized with COVID and have cognitive dysfunction have worse mortality, longer recovery times, and rehabilitation times. Myocarditis is also present in a high number of people with that type of syndrome, but myocarditis is a bit more difficult because you can develop myocarditis even with asymptomatic disease. And I'll review that in a minute. But these patients are ill and they represent post-viral states that are not due to the virus. So when you look at their hearts and their brains, you cannot find viral particles there. It is an autoimmune state, post-viral autoimmune state that has to be dealt with in a separate way. And antivirals are not going to help. So in this article last week in the New England Journal, they talked about microvascular injury. We've all heard about the little microthrombi that can happen in the capillaries. We've all heard about this, but they find it in the brains of these patients. Obviously, this is at autopsy, so these are the worst of the worst. I will show a slide because I love pathology, and this is not for you guys to interpret in the different boxes, but suffice to say, if you see the brown little dots in the lower rows, these represent inflammatory cells, and they're of the type of cells that are not acute, and they're not typical for straight fungal or other causes. So they're consistent with viral syndromes, but you cannot locate viral particles in these brains. But one of the things that is maybe in the category in the upper left called C, you'll see these little white dots, and they have little ischemic zones and little zones of permanent injury. And you can see it best in this D. And that's the worst case scenario where you're actually getting little mini strokes. And you can have the same situation in the heart. And this is an endothelialitis that I'll show here in a second, but this is again to show a tiny little blood vessel in the heart. But these brown signify immune cells that are stained by immunohistochemistry around these little small blood vessels. And this one in B shows a microthrombus. So this can cause heart injury. And this is not classical myocarditis. This is a vasculitis. With myocarditis, it's much more difficult to identify, but is now found with equal numbers. So when you have post-viral autoimmunity, is this new? Well, no, it's not. All these organisms have been associated with post-viral autoimmunity. And now COVID-19 is now going to be probably the largest experiment in post-viral autoimmunity for us to pay attention to as practitioners, because you can see it with patients that are sick. You can see it with patients that got only mildly ill. You can see it with patients that were completely asymptomatic, but it's a different course. That happens months later, and I'll explain why in a minute. You have three mechanisms. One is molecular mimicry, which is the virus itself contains sequences that are similar to our own tissues. And so because those sequences are similar, they can be mimicked by the immune system as foreign and then attacked. There's also the concept of activation of autoreactive T cells, and that's where they're primed. And that's where you can see that some of the patients with vaccinations, I think, that have emerged with rapid onset of multiple sclerosis, rapid onset of Bell's palsy, rapid onset of transverse myelitis, and these autoimmune states, when that more likely than not has excited their own reactive T cells that have been dormant. And then you have these people that have viral persistence, and that's because we're all immunologically different. And so some of us will never produce neutralizing antibodies to this particular virus or to other viruses. We will just never do that. So we'll have more viral persistence, and then the virus can mutate a little bit longer in us and then produce a more persistent state that then will eventually develop autoimmunity. So these three are the main things. And then you say all these conditions have been identified with COVID. The one on the bottom with Kawasaki-like shock syndrome in children that's had different names, but the children that get really, really ill, it's rare, thankfully. But it is a vasculitis-like syndrome. These are the antiphospholipid antibodies produce the thrombotic state. But interestingly, there's no evidence at all for worsening of the pre-existing autoimmune disease. That means that people with lupus don't have an increased risk. That's really dramatic. Of all the autoimmune states, lupus has a mildly increased risk, but that's about it. In the first bullet, all I want you to read is the last few words. It has generalized Bcell hyperactivation. So that if you measure antibodies, these profiles of serious autoantibody profiles, you'll find a lot of folks with persistent IgG antibodies to many different things. Of course, the most common would be antinuclear antibody. But this is the middle thing is the most important one. You can find autoantibodies in asymptomatic people up to 7 months after infection. And that's even without severe initial disease. And this explains the well-known situation where athletes and college athletes have been sidelined with acute onset of shortness of breath after they've recovered from COVID for weeks or months, and then they develop a myocarditis, which is, again, my area of expertise, and they have post-viral autoimmunity. So we have to investigate, and we have to look for these things and look for relationships between autoimmune sequelae and viral infection, even if the patients never got symptomatic. So I am a patterning type of person. I want to go over a few other patterns, and then I'll finish up and then open up for questions. You know, we all hear that convalescent plasma is effective, and I think that this is a fantastic solution for very early disease, in particular in high-risk people. Most people don't have access to it, but what I don't like is to have this, and then the next day you wake up in the morning and you find something negative that's posted on the media. And in this case, it says, oh, this may boost mutation risks and so on. So you have good news, and then always immediately next door to that is the bad news. And this is something of a pattern that I noticed with this pandemic more than any other infectious disease I've ever heard of before. And then, of course, FDA comes in and limits the use and so on. And it's sort of like this really works as it makes a lot of sense, and it would work with any situation like this. and then you find out that you have no access to it. And then Regeneron and Eli Lilly monoclonal antibodies work, but you try to get it at Stanford, UCSF, or the Mayo Clinic, and you can't get them. So it's there. We know that they're effective. We know all you need to have is an outpatient IV center. This is for prevention of hospitalization, and yet we still have 3,000 some odd patients a day dying, and this is difficult to accept. And the same with Eli Lilly. So these are approved, but unavailable largely. What we are stuck with is the PCR test. And you can barely see the right-hand part of the slide, but suffice it to say, at the level of thresholds that we look at 35 to 40, it finds a very, very small number of patients that actually have infectious virus or live virus in their system. So the one thing we do have is a test that is roughly difficult to interpret and roughly giving us a lot of false positives if you consider the positivity rate as someone who could be infectious. So this is back from the CDC's own data. So first they said that anything above 33 would be awful, and now we're at 40. And the more important one is here. There is very little correlation between the number of PCR tests performed in a country and any activity in terms of morbidity or mortality. So you can test all you want. If you only get the test results in 2 days or 3 days or 4 days or a week, they're roughly not very useful. This is one of the biggest things that differentiate us from the Asian population. Well, I do have a group in town in San Francisco that for $1,399 will pick up your sample and will get you the results in 4 hours so you can fly comfortably to Hawaii. The immunomodulatory strategies are listed here. I think we'll be posting them online. Suffice it to say that there are a lot of natural therapies that make sense. They're not approved, but the list is growing, and I'm sure this is not a complete list. But we have a lot of things that will work if you can get a hold of them before you need the hospitalization, and that's when you have fatigue and you're beginning to realize that you can't catch as much of a normal breath as you normally can. There are 300 medicines that are being developed and vaccines that are being developed. There's a lot going on in this field. And I think clearly for certain, out of this pandemic, one of the good news things that'll happen is that we'll have many more therapies for acute respiratory distress syndrome. So we'll have fewer patients developing pulmonary fibrosis in the future permanently. You have these markers. The marker list is a lot larger than this, but these are all inflammatory markers and coagulation markers. And you can add omega-3 fatty acid levels. You can add lymphopenia, but the markers are clear and they force us to go into the inflammatory world. We have the NFL. I mean, here's where dollars are at stake, lives are at stake. Athletes are super healthy, but they have to dorm together and so on. So we have the following things. They have much more sophisticated distancing software and mask requirements and so on. And they're not allowed to have close contact for more than 15 minutes. And they had a very low positivity rate, very low incidence rates and so on. And they had the entire season finished. What is, to me, the biggest lesson here is that indoor transmission was key to this. And that keeps on coming up over and over again. They do not hesitate to work together and play together in the outdoors and don't seem to have any associated risks that are increased. But in the wide open space, that's the biggest lesson for me, that I think that I would love the public health departments around the world to focus on. So the cold reality is this will be here for years or even decades, and we'll have to coexist with COVID-19. There'll be new strains that will emerge. This is just beginning. We have relatively sketchy access at this point, but worldwide we have poor access, and then it'll become an endemic disease. And I expect, and we should all expect, that deaths should plummet after we vaccinate our high-risk populations, because only 35 million people occupy 80% of the population that have died. And we will have to continue these types of prevention methods. And when we have patients that have had the disease and are recovered, or we've gotten vaccinated people, I don't understand how we'll not be forced to mask for a longer period of time, because we won't know if someone has had the disease. We won't know if someone has been vaccinated. And I don't want to wear, a mark on my coat that tells people I've been vaccinated or not. And in the future, certainly public expression of ourselves in the normal public, we should assume that this will be lasting for years, that we'll be required by the governments to act in a certain way. I think that's it. Thank you very much for your attention, and I'll open it up for questions.
First question, what is your opinion on the drug ivermectin to take at the onset of COVID or for prevention?
I think ivermectin came up. Colchicine has also come up as an anti-inflammatory. A lot of the antiparasitics and the anti-helminthic drugs have shown in small studies to be effective. You could argue that ivermectin is more easily used in Africa and so on, and that's why the numbers are lower than ours and unanticipatedly lower. But I haven't studied it, and I haven't tested it. I have no idea how that data will ultimately be useful. But some people will have access to it and will be happy to take it if they get early infection. But I'm not recommending it to my own patients or to myself at this time, and the same goes with colchicine. So I am an early proponent for hydroxychloroquine again, but I don't think we'll ever get to a point where we'll be able to adequately convince the public and convince the public health agencies that it has some efficacy.
How will vaccines affect marginal zone lymphoma?
Maybe someone has a particular case about someone with lymphoma, and are they at risk to take the vaccine? And if you have issues with the current vaccines and you say, I don't understand what the long-term sequelae may be, then you can wait for the single shot older style vaccines by J&J. But I'm not recommending to any given person to delay vaccination if you're in a super high risk group at this time. So again, I have patients in my practice who will not take the current vaccines, and probably will not take any vaccines. But it's really a case-by-case decision.
Do you anticipate the vaccine for COVID to be mandatory?
I don't know. Do I foresee it? I think it would be very difficult to execute in the United States, because you have to have a rational, risk-benefit perspective. And so I certainly don't see the rationale, no clear rationale for the younger populations at all. So except to say that if you're asymptomatic, you could give it to somebody, but there's very little information about that. I can say that, I think I much more foresee the onset of a new vaccine era where we'll need to take multiple vaccines to be able to, or prove that we have had multiple vaccines to prove that we can be allowed to be safely in public. So in that sense, at some point, we have to really take this extremely seriously. I think that the economists have suggested that, and the finance people looking at how we'll return back to normal, expect us to be all vaccinated.
Would you please list what autoimmune antibodies you measure after COVID?
Well, again, I think if you have someone with a high D-dimer, which is a coagulation profile abnormality, then I would look at antiphospholipid antibodies. But the screen is an ANA, and you do an ANA titer. If it's positive, then they subtype it and so on. And I've seen Sjogren syndrome, so the SSO antibodies be positive, the antiphospholipid antibodies, the ANA. And then there's a Cyrex panel for multiple autoantibodies that I think is Cyrex 11 that one can use too. That is a pretty extensive list of autoantibodies that you can use.
Would there be any benefit in taking a double shot vaccine in combination with a single shot vaccine?
Well, if you're going to get 95% efficacy with the double shot, and you actually you never develop disease, and you have high levels of neutralizing antibodies, and we won't commercially measure memory T cells ever. So that's the problem. So we may have to do multiple vaccines because we're not going to do the testing to prove that we're already immune. And that's why the variants become so important as an negative force here rather than a positive force. But to then take a single shot vaccine, I mean, if it's up to you. But I think the question is, how many hepatitis vaccines do you want? Do you want to take the usual 2, or do you want to take someone else's hepatitis vaccine to be more protected? So the question is, protected from what? So at some point, when it's the overall incidence is much reduced, then we'll have a different set of debates.
Can you tell us about ozone therapy used successfully in Italy?
Well, yeah, it's also been used anecdotally by certain ozone physicians in the United States, and it does have theoretical benefits that are, all fit both antiviral and immune regulatory. So it can add ozone to the list, but it's never going to be officially studied. So that's been the problem. But I think it's a great idea. Also, a great idea in my opinion, as a measure to consider before you take the vaccine. So what I tell people, if you have, really concerned, then come in and get ozone, get glutathione, and make sure your vitamin D level is really sufficient. If you can't get IV glutathione and ozone, then make sure you have a very good formula of liposomal glutathione to take before you get your vaccine, because really it's just an exaggerated immune reaction that you don't need to have fever. You don't need to have malaise, myalgias, and arthralgias to get the benefit. And obviously you could take Tylenol before as well. So as long as you're not dysregulated, you're not inflammatory, you'll probably be okay if you want to take the vaccine or you have to take the vaccine.
Why do you anticipate the spike of autoimmune diseases after our mRNA vaccines?
Well, I anticipated after not so much the RNA vaccines per se, but because of coronavirus itself. So it seems to cause a lot of system-wide damage that is only on the spectrum of the most severe types of viral diseases that we've had. And we've already seen evidence of post-viral autoimmunity. And then we've seen individual cases of autoimmunity that have been well described in the lay press after vaccination. So I'm concerned about RNA vaccines really as a big question mark. That's all. It's a question mark. We don't know what we don't know. With adenovirus, the more older technologies, we do know what they can do. But we've never had one with coronavirus per se, which seems to be a particularly difficult virus or spike set of proteins that produce immune dysregulation. So, I mean, it's just a question mark in my mind, and we should be aware of it. That's all. And when I see the college kids develop myocarditis, that raises my flag up, because those act like the enteroviruses and the Coxsackie viruses and on the influenza viruses, that these happen, but it's being exposed more. So maybe it's not anymore, and maybe the incidence isn't greater, but I think it probably is.
Some people have had symptomatic diseases and tested positive have antibodies, and others do not. What is the best test to assess antibodies, especially T cells?
There is no commercially available test that would measure memory T cells to the virus. That's a laboratory research tool. And again, I think about 95% of the people will have a normal level of set of antibodies, but there's about 5% that are PCR positive. They clearly were sick, but they were PCR positive. And then you look for IgG and IgM antibodies, and you never find them with the commercially available tests. And you do it repeatedly, and you still don't find them. So these are folks that, I'm not saying that they're necessarily sicker. I'm just saying that there are different immunological pathways to go, and they may get over it completely on the basis of their T cells, and they're not necessarily sicker, but they more likely not have viral particles a little bit longer than those without the neutralizing antibodies. And so we don't know. There's awfully little information available on if you got screened in the hospital. We know what biomarkers to look for, but we don't know anything about the immune genetic patterns, except for just maybe 20 or 30 patient studies that have been done back in April. We have very little additional information.
Okay, well, I think that wraps up our time today, but thank you very much, Dr. Herskowitz. It's been a pleasure. And thank you everyone for joining us. We will be sending out this recording in about 2 to 3 days with updates on other opportunities for ACAM. So have a wonderful evening.
Thank you.
Bye.
Bye.